Can everyone see my slides okay? Um,
Yes.
Perfect. So as Jerome said, my name's Andrew Jacques. I'm the Transplant Surgery Fellow at Royal Prince Alfred. I think the topic for today is, it's a normothermic regional perfusion, and with really a focus on some of the ethical and legal considerations for this approach. But it would probably be incomplete without just a little bit of background around the technical components relating to this approach. So just an overview of my presentation, just a bit of a discussion around what the problem we think NRP is actually potentially trying to solve. And I suppose the problem in transplant is relating to organ availability and using, I guess, DCD grafts and the warm ischemic insult that occurs with the DCD process, and how NRP can potentially minimize the risks associated with these grafts. So we'll talk about the technical aspects to NRP, the evidence that's been generated relating to NRP, and then a little bit more of a focus on both ethical and legal considerations for NRP and how it relates to our context specifically. Now hopefully we can have a bit more of a conversation about how we move forward with this approach in Australia and New Zealand, and finish with a conclusion and some discussion. So to start, what's the problem we're trying to solve? So I guess most transplant discussions start with the problem being relating to organ availability and waitlist management and supply versus demand. And there's always an ever-growing demand for organs for transplantation, and whether that's an expansion of criteria or just growth of established chronic diseases, this expansion of demand is never really met with an optimal deceased donor pool. And by that, I mean, the brain dead donor who's young and otherwise fit and physiologically normal. Now, DCD practices have significantly increased the quantity of organs being utilized, but these grafts, because of warm ischemic insults, have an overall reduced quality, and there's a reduction in the utilization per donor. And in light of the shortages and limitations of DCD, there's internationally a rapid sort of development and interest in various perfusion technologies, one of which is NRP, which we'll discuss today. Now, I've just got two graphs here which don't really tell the full story, but just examples in liver transplant. These are both from Australian and New Zealand data. The first on the left is you can see the growth in liver transplant activity each year, except for a small drop probably in the last few years, probably related to COVID. And at the bottom of the graph, you can see the DCD transplantation is the vast minority of livers that are transplanted in Australia. I think my personal experience of the last 18 months at RPA, I think it's 6% of the transplants I've been involved with have been DCD. And then again, Australia and New Zealand data, looking at the graph on the right, the DCD grafts in liver transplantation have a worse long-term survival. So they're not able to meet our demand, and they seem to have worse results. Now, there are limitations with DCD, as I alluded to, and normothermic regional perfusion may have a potential role. So DCD procurement, as we all understand it, it proceeds when the possibility of order resuscitation has passed, and a decision has been formally made not to attempt resuscitation. It's limited as an approach because of the damage that occurs during warm ischemia, and limiting warm ischemia, if possible, has the potential to benefit the organs and potentially the transplant recipient. Now, normothermic regional perfusion aims to address exactly this. It aims to minimize or partially reverse ischemic injury. It does this with in situ restoration of organ perfusion following the declaration of circulatory death. So probably the simplest version of this to someone who hasn't thought about it before is it's a regional ECMO to re-establish oxygenated perfusion to an organ. Now, the approach has been enthusiastically endorsed by some, and some countries have taken on very readily, and it's been criticised by others. And as yet in Australia, it has not been adopted. Just focusing quickly on some of the technical considerations, there's a few different flavors of NRP and different versions of the same technique. It can be either isolating the abdominal organs or can be thoraco-abdominal, and it can be done with either open or percutaneous techniques. So this is a graphic from a paper by Hesheimer in 2019 in the Journal of Hepatology, and it's a Spanish group who are more early and rapid, enthusiasts for the technique. And this image demonstrates a percutaneous approach where a balloon has been floated to occlude the descending thoracic aorta, and then there's cannulation of the iliacs to establish a circuit that's controlled with a pump and an oxygenator to allow oxygenated perfusion of abdominal organs in isolation. This is the crux of NRP. And we'll talk about evidence a little bit later, but there's this graphic also shows some of the results that they've demonstrated, that when compared to DCD and using super rapid recovery, there's a significant reduction in biliary complications, ischemic type biliary lesions, and graft loss related to the reduction in warm ischemic injury. Now, abdominal NRP, so much of this is, I've described is related to an oxygenated blood being pumped with an extracorporeal circuit that has a cannula that sits in the aorta and drains with a cannula in the cava. And as shown on that last graphic, it can be done with cannulation of the femoral vessels. Now, the descending thoracic aorta and IVC are occluded above the diaphragm, and this confines the circulation to the abdominal cavity. Variation of this technique, which introduces some additional discussions around ethics and legality, is thoraco-abdominal NRP, and this is where both thoracic and abdominal organs are perfused. And in this situation, the thoracic aorta is not occluded, but there needs to be a system in place to prevent blood flow, to prevent cerebral blood flow. And the vessels off the arch are occluded or ligated as part of this technique. Now, some people have criticized this approach because of potential collateral flow that may lead either via intercostals or other avenues, may potentially re-establish some component of the basilar flow, which raises some questions around the ethics of the technique. Now, this is a meta-analysis looking at the results that have been published to date. Now, this is pooled data of more than 700 controlled DCDs using abdominal NRP in Europe. Keeping in mind, however, I mentioned before that in Spain, they've been more aggressive with the technique, and I think over 500 of these 700 are from their experience. But the pooled results are positive for DCD livers with very low rates of ischemic cholangiopathy, very acceptable rates of primary non-function, and good graft and 1-year patient survival. Now, I guess trying to get into some of the ethical and legal discussions relating to NRP, and really trying to talk about some of the potential barriers that exist to pursuing this technique in Australia. If you do a PubMed search of ethics and NRP, immediately it comes up with lots of discussions recently published with point, counterpoint. Is NRP ethical? Yes. Is NRP ethical? No. And I think it's important to recognize that there is at least an international discussion in this space, and I think it's warranted to have the same discussion here. Now, thinking about the ethical principles, I think the main things are probably non-maleficence and doing no harm, autonomy and utility. And I think non-maleficence is probably the most important to recognize. Now, we are all familiar with this idea of do no harm. And in the transplantation space, this requires compliance with the overarching dead donor rule. Now, the dead donor rule really means for us that the deceased donors must be dead at the time of procurement, and organ donation itself must not cause death. So one question that is being posed is, does NRP violate the dead donor rule? So does NRP cause harm, and is NRP therefore unethical? So the crux of that is the question, does the recommencement of circulation regionally violate the circulatory criteria for the determination of death? And I think that's where there's a significant amount of debate currently. I would advocate that it does not, but that's a discussion that we can have after I finish. The next point relates to autonomy and respect for the donor. And I think this technique has unique components. And if we were to adopt this approach, it would require transparency and informed decision-making. So there needs to be informed decision-making with donor families, and there needs to be some acceptance that perspectives on NRP may vary. So unique aspects of NRP should be disclosed. Circulation will be restored regionally in abdominal NRP, and that can include the heart and thoracoabdominal, and that's in a patient who has not been assessed to be brain dead. This is in the context of circulatory death, so that needs to be disclosed. The other issue ethically is relating to utility, and there's the potential for this approach to increase both the number of organs per donor and also the quality of organs, which is virtuous and beneficial, but I think utility in itself does not necessarily override some of the other ethical constraints, such as the potential for the violation of the dead donor rule. So while justification on one principle is necessary, it's not always sufficient to make us conclude that NRP is appropriate. Now, talking about some of the legal considerations, and I know Jerome paid tribute to some of this debate before I started, but I mean, ultimately, the deceased donor rule is a foundation principle, and it's a useful concept, a conceptual framework for us to work by. But death can be, surprisingly and exceedingly difficult to define, both medically and legally. And just trying to explore how different countries with the same language and the same culture have approached this, looking at the United Kingdom, Canada, and New Zealand. There's no statutory definition of death, but rather the definition comes from case law or existing common law based on the central idea of an irreversible cessation of brainstem function. Now, in the USA and Australia, there are statutes in law defining death. In the United States, there's this, I've discovered this term, the Uniform Determination of Death Act, the UDDA, which has been adopted by 37 of the 50 states. Now, the determination of death occurs when either one of two events occur. So one is the irreversible cessation of circulation and respiratory function, or two, the irreversible cessation of all functions of the brain, including the brainstem. Now, in Australia, our language is actually, to my eye, very, very similar. At least where I am in Sydney, we have the New South Wales Human Tissue Act. And I think it's near word for word as I read it. There's one, the irreversible cessation of circulation of blood in the body of the person, and two, irreversible cessation of all function of the brain. Just taking a little bit of a step back and thinking about how the law in Australia has been applied to deceased donation. Now, currently, deceased donation as practiced, if we were to take a very strict interpretation of current law, we can make an argument that DCD donation is vulnerable. We require the irreversibility of circulation. However, we know that if we reintroduce life supports and someone who has had a circulatory determination of death, if we reintroduce intubation, oxygenation, CPR, defibrillation, ECMO, we can potentially reverse the irreversibility, even though it's in the context where that is deemed not to be appropriate. Now, that could potentially open us up to legal action, but it never has. And I think this risk of legal action is very low. And I think it's supported by the fact that current practice has not been attacked legally. There's been a lack of action initiated by any of the concerned parties. And that probably relates to people in the donation space, the retrieval space, and the family members all being consenting to what has been done. And there have been select court processes and proceedings that relate to declaration.
Can you call Amy, Daddy?
But not donation itself.
I'm on a webinar.
One
Sorry?
concept I wanted to talk about that.
Sorry, Yulin, can you mute, please?
Sorry, one thing I wanted to bring up, which actually hasn't been a predominant theme in a lot of my reading in this space, but something one of my counterparts has sort of introduced to me that I really quite enjoy is this idea of the fallacy of composition. And if I just provide a little bit of context, there's always been a portion of the community that has struggled with either the ethical or the logical or the legal position of deceased donation. And that's not necessarily wrong, but it reflects individual perspectives or cultural perspectives. And we see that in other countries that have much lower rates of deceased donation, such as Japan or South Korea or Saudi Arabia. And equally, at every step when we've had some change in donation practice, debate has followed. And that has occurred not from lived experience, but from what I've read in the defining of brain death, the defining of circulatory death, heart transplants in the context of DCD donors, and heart in the box, ex vivo cardiac perfusion. Now, I think one thing that people who have objected to some of these pathways do is they commit a logical fallacy where they say, just be patient with me if I explain this. If a part of the whole has a quality, then the whole has the same quality. And if I apply that logic to, let's say, DCD heart transplantation, if we say the heart is alive, then the whole person is alive. But we don't see that to be true in DCD heart transplantation. So I think this is the fallacy of composition, that if a part is alive, then the whole part is alive, which I think is fallacious logic. So the fundamental principle that underlies deceased donation is that the person is deceased, but the organs, through recovery and resuscitation, can be utilized and are alive. So a part is alive, a part can be resuscitated, but the whole is deceased. And if we extend this logic to regional perfusion, we're looking to introduce a more complex technique to provide regional or part resuscitation. And that is not the same as resuscitation of the whole or re-establishment of life in the patient. Now, the question is, does the law need to be changed? Now, some would argue that NRP cannot proceed in Australia without a change in the legal definition of death. Now, I would say in the United States, from my reading, there has been no legal consequence. There has been debate and discussion, and it's actually probably, in my opinion, centered more on the ethical grounds than the legal grounds. But there's been no legal consequences of those who have undertaken NRP with very similarly phrased legal definitions of death. I think it's reasonable to conclude that there are limitations in language that are inevitable when trying to define something that is so hard to define. And that raises the question, if we were to change the language to define death, to what would we change it? And if we were to change it, I imagine that would have unforeseen challenges or for either other aspects of medicine that work in parallel with us currently, or potentially even for transplantation and deceased donor practice in the future for reasons we're yet to see. So I think there are limitations with pursuing changes in the law. Now, just to sort of conclude this with some more personal perspectives and conclusions, I think it's reasonable to say that NRP has the potential to increase organ quality and organ utilization per donor from DCD donors. I think NRP as a practice is supported by evidence, and that's evidence being generated with a lot of enthusiasm by international experience with people with very culturally similar ideas around donation. Some of the ethical considerations, I think it's appropriate for us as a community to consider whether NRP violates the dead donor rule. I think utility arguments are worth listening to, but they don't overcome the concerns if they exist relating to non-maleficence. I also think because of the unique aspects relating to NRP, transparency and informed consent are essential if this were to be adopted. Legally, legal action has not historically been a concern with current deceased donation practice. I think strict legal interpretation of the definition of death brings into question not just NRP, but if we were to truly be very strict in our interpretation, it brings into question DCD practice and also all of deceased donor practice, so not just NRP. Now, I personally am of the opinion that resuscitation of the part does not equate to resuscitation of the whole, and that's in keeping with current practice. So for deceased donation to exist, the donor must be deceased while the organ must be alive. Now, one thing that hasn't been discussed today, but would have to be considered if this were to be adopted in Australia, is some of the system and implementation considerations relating to training, resource allocation, protocols for how this is utilized, but that's probably beyond the scope for today. That's the end of my presentation. So please, I'd love to have some questions. I'd like them to be directed at Jerome, not me. So thanks very much.
Thanks, Andy. That was a very interesting talk. I'm sorry, I missed the first part of this discussion. My understanding is that potentially in New Zealand that they are going to introduce NRP. And I just wanted to know whether or not there were any sort of other legal barriers in that jurisdiction that you know of that might affect the implementation of NRP. It's just because since I've come back from Edinburgh where I did abdominal NRP, it's been increasingly apparent that we will have a lot of barriers in Australia. Thanks.
Yeah, I think, I mean, my reading of it is that in New Zealand, the current legal standing is very similar to the UK. There's no statutory declaration to state, a legal definition of death. It's largely in the hands of the medical world, and it all centers relating around the cessation of brainstem flow. So I think the New Zealand context legally, as I see it, is very similar to that in the United Kingdom.
I think, Andy, that's true. But one thing I would say is that there are people in the United Kingdom who find NRP incompatible with their brainstem focused common law idea around the definition of death. So it's really, I still haven't found any community with any definition of death for which this issue is not contentious. In other words, the people enthralled to the fallacy of fallacy of composition can be enthralled to it irrespective of what the legal position is with respect to the definition of death.
Hi, Andrew. Thank you for the nice presentation. I have actually a lot of questions, but I think I'll ask you, like in our DCD practice currently, I do understand the dead donor rule, but in our normal DCD pathway practice, what normally happens is during the donor meeting, we have this negotiations that happens with the ICUs. Do we give heparin? Do they, are they happy to give, etc. As well as the anesthetist comes around and says, or the ICU guys comes around and says that they will make sure the patient has, a good comfort measures in terms of adequate morphine and so on and so forth. So in a way, we sort of do not fulfill the dead donor rule. Now, so with that in mind, can I ask, I'm not too familiar with NRPs, but the intervention as far as putting the cannulas and stuff like that, does that happen before the declaration of, in a way, cardiac death, cardiocirculatory death, or respiratory death that happens, or is it done only after the declaration of death?
It would be only after the declaration of death had occurred and the stand down time. So it would be in just exactly what our normal DCD practice is. Michael Finks raised a very interesting question. So Michael says maybe it would be helpful to keep the two current definitions of death and add or the irreversible cessation of circulation of blood in the brain of the person. And I think that's really interesting, Michael. And I think it's really great for us to throw around ideas about, what words we'd add. But for example, if you use the word irreversible, which means could not be reversed, how do you how do you overcome the fact that you could reverse it? Like, you'd be very perverse to do so, but you could just intubate them, give them CPR. You could use percutaneous ECMO, VA ECMO without any other control. So the word irreversible, with an understanding that that means could not be reversed, which is a very, like, that's the dictionary definition of the word irreversible, is incompatible with the exact words that we're using. So I think, in every single addition to the words that I come up with in my mind. So for example, I've added the word in my mind spontaneous before the word irreversible, or irreversible spontaneous cessation, irreversible cessation of spontaneous circulation, right? So spontaneous, what does that mean? Does that mean that if the heart then restarts after the initiation of thoracoabdominal NRP, that's not circulation, or that's not irreversible, or it's not spontaneous? In other words, we can't define death to the second using the English language, or, and I suspect, any other language.
Yeah, I agree, Jerome. And the other issue with adding spontaneous is it means if somebody dies and you resuscitate them, they're legally dead then, aren't they? Because they haven't spontaneously.
Well, yeah, that's right. So,
covered.
we've got to remember that this law is used when people are found decomposed, in riverbeds, and when people are found with rigor mortis in their house. And, it's a law available, which is by its very nature deliberately vague, so that doctors and the legal profession can use it as they need. And, we've used it as we need. The fact that it's actually, kind of perverse in the way that we use it, in the sense that it's funny, in the literature, they said that the word irreversible has been interpreted as the word permanent. It's a very common statement in the sort of ethical and legal literature on this topic. But when you start to think about the word permanent, that's equally unsatisfactory. Like, it's not, it's permanent by intent, because you intend not to reverse it. Like every word that you can potentially come up with is either itself clearly problematic, or could have some other unintended consequence that you don't intend to have. And, one of the things is, as a transplant community, and particularly, we need to also get intensive care to engage, but, the process that's been initiated through TSANZ is one of approaching the Attorney General of the Australian government to change the law. That will never work. I'm telling you right now, because we don't know what to change it to. And how can we ask a group of people who, let's call them ethicists. I don't know what an ethicist is. It's someone who thinks that they have a really good understanding of ethics, or a legal mind, who has no fundamental understanding of the medicine that we're discussing. How can we ask them to change a law to allow us to do something when we can't even find the words to describe what we want to do? And more importantly, no one's objecting. And also, we're not proposing to have consent-free donation. Like, we're not proposing that people should have, coercive processes regarding consent imposed upon them. We're talking simply about the same process that's been going on for 30 years, basically in contravention of a interpretation of the words in the circulatory definition of death, being changed slightly and reused. And I think that as a transplant community, we need to advocate very clearly for that, because if we advocate for law changing, we're going to still be here in 20 years.
I agree with the sentiment. I can sort of understand people's take when they're concerned about the fact that it's restoration of part of the circulation of the person. So I can see their concern. And so if we specifically cite the brain as the thing where the circulation is stopping, it would be more logical, wouldn't it? Whether it's feasible to change the law is another question, but that would be one approach at least.
I think for me, when I sort of think about the way to approach the problem, is just to indicate that what we're talking about is perfusion of organs in situ. So there are multiple dictionary definitions of death which require a circulatory process to be integral. In other words, it involves the entire circulatory system, and many of them require that to be driven primarily by the heart. So you can quite easily argue that NRP is not circulation. So if you want to have a way to integrate this with the circulatory definition of death, we just need to be consistent about our language and say that we're not talking about, when people use words like reanimation, that's very unhelpful. When people even use words like circulation or ECMO, because it's not very clear what they mean, it's easily subject to attack. But if you just use the word perfusion in situ of the organs, then everything else follows. For example, it makes sense then to clamp the subclavian, carotid, femoral arteries, because you don't need to perfuse the legs, the arms, or the head. You just need to perfuse the organs to be transplanted. So it's really, you can only fight semantics with semantics, because the issue is not fundamentally semantic. The issue is fundamentally how people approach culturally death and donation. And, I would say 90% of the population would not want to be in a deceased donor. They would find it repulsive, and that's fine, but someone's got to do it. And the community, I think, supports it. We don't want to end up like Japan, where, the only donation options are living donation or death.
Santosh, you're muted if you're talking to us.
I think one of the things that, sorry, Santosh, if you had some question to ask, or
Yeah, no, I was just saying, Jerome, that if we just define DCD as cardiac arrest, cardiocirculatory arrest, respiratory arrest, and give the currently what we follow is a 5-minute timeout time. Instead of the 5-minute, go to 10-minute, as some groups believe we should do. And then would it be easier for everybody to accept that as death?
That'd be worse for the liver, though. The liver's really marginal in terms of the time.
it would make no
5
difference
minutes.
it would make absolutely no difference to the people who have ethical concerns like that. From their perspective, the only time that it would be acceptable to do this is when the circulatory system is completely clotted and you couldn't circulate, because that's what it means, right? Irreversible cessation of circulation. You put cannulas in and you can't circulate anything because there's diffuse intravascular thrombus formation. So the only way that people who have this view of the circulatory definition of death could be satisfied is a way that's incompatible with organ donation.
Can I just ask, this is Susanna again from RPA. In other jurisdictions outside of New South Wales, has anyone else heard from the Attorney General in response to the request to review the definition of death? I understand that a letter went out on behalf of TSNZ with some of the transplant community as signatories. Okay, I'll take that as a no.
Yeah, I'm not sure whether that has been responded or not. Blanca, sorry, by the way. So I think it's a very, very good topic overall. Its area has been discussed recently, try to increase the organ quality after DCD donation. But I think it's quite interesting. Depends. My take is it depends how you understand all this. Like, even in DCD donation, currently some areas that don't even giving heparin, they thought that's not ethical. Somewhere being giving heparin after declaration of the death, etc. So that's just a different. I think it's a diversity of opinion rather than up to the level of the law making or more law changing. So just coincidentally, there's a publication on transplantation in August. Actually, international author, Australia, like Helen is also a group, and another 2 people from law school, etc. I think that paper I will forward to everyone to read. Very interesting. So I think we probably should prepare to start something like this, to initiate whether we should start ARP sooner rather than later, particularly for liver transplant. I think it's great value there, isn't it?
Like one thing I would say is the benefit in kidney transplantation is doesn't appear to be primarily a change in the outcome. DGF rate or anything. The primary difference in outcome will be the total number of people who can be donors. In other words, it may increase the number of people who, because you typically don't use, have very prolonged acceptable agonal times in NRP. So rather than waiting 1 hour or 90 minutes, people may wait 4 hours. So that increases the total number of DCD donors that proceed. And then
that's true. That's another like a subject, talking about how long you should wait. Like normally,
that's
90
right.
minutes defined by just a legal like logistic issues. Whether we should extend to, I mentioned about 4 hours or at least 3 hours, or it depends on the donor condition. If you force you wait another 20, 30 minutes, you will get another donor will be great, isn't it? Rather than just cut off 90 minutes.
That's right. So and it's actually impossible to get that data because no one can tell the donor they would have got if they stayed longer, or donor they would have got or the donor that would have proceeded if they'd had a different system.
In fact, we did in Victoria just started looking at this data. We do have the donor not die within 90 minutes. However, that died the next 2 hours, or we do have a little bit of data that we are going to look at to see potentially we could like increase about 20% donation if we increase to like 3 hour, 2 hour and a half, for example. And then we have data from Donor Life. You may ask them, they may have.
The other thing is we don't know how people's end-of-life care practices would change following withdrawal of life support if they know this, that if the intensivist knows they're there for 4 hours. So there's all sorts of imponderables about what the outcome would be using different systems.
Jerome, see, Andrew quoted that Spanish paper about 700 so donors. Now, what I'm curious to know is that what was the discard rates? Because, see, this is a group of patients where the discard rates are going to be pretty high. See, as you mentioned, non-maleficence and do no harm. It is to the donor as well as to the recipient as well, right? So the fact that we sort of negotiate with the ICUs to give the heparin and all that sort of stuff, so that, to prevent thrombosis and, better quality of organ. So in a way, we are sort of, it's important for us to give good, handover or transplant good organs to the recipient as well. So what is the sort of discard rates that we are talking about in this NRP?
I think Henry just did a systematic review on it recently. That the discard rate seems to be in, not just the Spanish experience, but overall around 20% of NRP DCDs. Actually, sorry, that might be the liver discard rate. So the liver discard rate is 20%. I'm not sure what the kidney discard rate is.
The kidney discard rate around the world, particularly American and UK, is 20%. And DCD discard rate in Australia is about 15%. And most of the reason for discard is due to poor perfusion. That's our study recently from ANZAC data, I think published by Sydney Group somewhere last year.
I'd say anecdotally from the UK experience, the discard rate for DCD donors in the context of DCD NRP is generally quite low in experienced centres. I understand that, for example, in Edinburgh, where they have increased their numbers of DCDs, abdominal DCD NRPs, they've increased their liver utilisation by about 50%. And the discard is usually due to either poor donor qualities or there's been an issue with the actual perfusion, but I think it's actually quite low. And so I think that's sort of the impetus to drive the NRP in Australia and New Zealand, obviously with current great difficulty.
Suzanne, is there an age cutoff for this criteria, or is it a very highly selected patients that is taken up for these DCD NRPs for liver?
So I think with experience, they've expanded their criteria greatly. And I think the oldest donor was probably an 8-year-old DCD. But I think what they're doing now is because they're going to these, for example, DCD kidney only retrievals and running NRP, and then because the liver had not previously been offered, they've noticed that with the parameters on the NRP circuit that the lactate and the LFTs are improving, so then they'll choose to use those livers. And that's sort of like a Edinburgh specific or Scotland specific practice, because they get offered these donors and they can use them. So that's why they've been able to increase their rates.
Sorry, by the way, Susan, would you mind give a little insight about how they do this like a normothermic regional perfusion technically, very briefly? So it looks like you've done some in Edinburgh.
Yeah, so I trained in Edinburgh, and we mainly did abdominal NRP only, or abdominal NRP with cardiac straight up DCD. So I never did thoraco-abdominal NRP, but yes, I can discuss with everyone about the technique when it arises. Thanks.
That's good. So you did a cardiothoracic, not doing abdomen, is that?
For example, if there was a DCD donor that had viable heart and lung for retrieval, then the cardiac team will take the heart and lung as a straight up DCD while we perfuse the abdomen with NRP for 2 hours. But they had to take out the heart and lungs quite quickly, ensure that there was adequate hemostasis in order for this to actually work. And the few times that it sort of didn't work was when there wasn't enough hemostasis in the chest and there was too much blood recirculating. But that's, I think it was always a complex retrieval in those settings.
What machine do they normally use for normothermic regional perfusion to the abdomen?
They use a Mackie ECMO circuit machine, which they could sort of dismantle, put on a plane, and then rejig it in whichever hospital it was. Like we would sometimes fly to Belfast and do NRP, for example.
Do you need a particular like a cardiothoracic perfusionist, or just a perfusionist for organ retrieval?
A perfusionist. So they trained nurses to be able to run the machine. Like you can do training with it, but they paid nurses sort of above the normal rate to run the machine specifically, and they're very good.
Yeah, that's good to know.
And
so just to come back a little bit in terms of this definition, I think very interesting, because if you declare the patient dead and then become a donor, then you proceed for donation. Whether we should mix up about irreversible circulation, etc., because you declare the dead, then we do something as a consequence, not like a intervention. That if we separate the two concepts, basically is the acceptance. If everyone else accepts this concept, then you can just proceeding like a DCD donation, you start. As Andrew mentioned, if you really pick in details, so the DCD is not really legal either, isn't?
I think there's sort of this really comes deeply down to the philosophy of law, Boulain. So, like basically you can put anything into a law, right? Like you can write any law you want. Like Stalin had all the laws that allowed him to deport people to the gulag. But in the end, the real laws are the ones that are discovered. Like they're discovered by human beings who found that if they followed these laws, they are more likely to survive and prosper as a community. And these are laws like don't steal things, don't kill people. Like those are fundamentally, result of essentially co-evolution of human behavior and rules. So if you consider what donation is, deceased donation is basically a literally illegal law, illegal by the literal definition of the law, probably both DCD and brain dead donation. But because the word irreversible is not correct, consistent with what we do, but it is completely accepted by our community. So what we have is something that is literally illegal, and on a very fundamental sense, in accord with all of our feelings about what is right, and it enables us to flourish as a community, to look after people with end-stage organ failure. So it's really important that we make this argument clearly as a community, because if we think that someone else is going to fix this, no one can do it. So, for example, just to explain very clearly what Susanna said, or just to rephrase it for myself, in fact, if you're doing abdominal only NRP, you're talking about the perfusion of organs where the highest level of perfusion is the distal thoracic aorta. The highest level of antegrade arterial perfusion is the distal thoracic aorta, and there is no venous drainage above the diaphragm, and the heart and lungs are physically absent, and the neck vessels are physically open to the chest. So, in other words, the carotid on both sides and the innominate are the innominate artery, the left subclavian, the left carotid are draining. If there is any perfusion, will drain into the chest cavity. The idea that still is an integral circulation, it doesn't make any sense to me. I don't know how you could claim that, that a human being without a heart has circulatory capacity.
It's impossible you will reverse like a brain function, otherwise the patient will be survived.
Well, we'd have to. It would take a lot of effort, right? Like I can't even imagine how you would reestablish. How would you reestablish continuity between the ECMO machine, which is driving their circulation, and their blood vessels, which are separated by 60 centimeters, with no contiguous vessel? It's a ridiculous idea. So I think we've got to make those arguments very clearly, and it's not conceptually either good or bad. It depends specifically on what you're talking about and how you describe it.
Sorry,
acceptance.
Can I just interrupt? Sorry, I just want to know, what interventions do you do before you start, what interventions would you do before you declare the patient dead to start NRP? Is there any interventions?
So in the United Kingdom, antemortem heparin is not permitted, the same as in New South Wales, and NRP proceeds fine. You can give antemortem heparin; it probably helps, but it's not necessary. So you could do this without any antemortem intervention whatsoever.
Any other comment from others? I saw Amanda there.
So I was just wondering, in this group, how many people would be very happy to give antemortem heparin in a DCD patient before retrieval?
Or many states have already started this practice. They give heparin already. Some states just been stuck there, not comments to practice giving heparin. That's not uniform even in Australia, as I know.
I think New South Wales, it's not permitted. So actually, there's a very interesting question. So one of the propositions is that we should simultaneously ask the government, the federal government, I presume, to change the law so that antemortem interventions across Australia are unified. When you consider the process of law changing, what that means is that, and if that's bundled up with the change in law in the definition of death to allow NRP, the proposition is that something that could potentially increase liver donation by 30 to 50%, kidney donation by probably 30%, is going to be tied up with something that's desirable but not essential. In other words, a law to change the ability to give antemortem heparin, and a change in the law which has zero prospect ever of producing anything useful. So, as Boulang says, it's about the acceptance. It's not about the law. No one's ever even tested what the level of acceptance is, because the proposition from OTA has been that this is illegal. Like, you can't decide whether you're going to accept it if you think it's illegal, right? Like, no one's going to have a debate about whether murdering is appropriate if you think it's illegal, which I'm sure it is. So, but this what we're discussing is actually in the fundamental sense, not illegal. And so really it's just a question of finding out if there's an acceptance of it. And actually, does it matter really if someone whose relative isn't deceased and who isn't an intensivist or a transplant surgeon, does it really matter how they feel about post-death donation practices? In other words, are the opinions of a completely uninvolved third party to supersede the opinions and views of the three fundamental decision makers in this process? The relative of the deceased person, their surrogate decision maker, the intensive care team looking after the patient who's deceased, and the transplant team who has to do the procedures. Like, they're the three fundamental stakeholders. And in a really important, so if we send out a survey, we'll find that like pretty much everything, about 70% of people support donation, and about 30% of people either don't or are not sure. So if like that's the outcome of every donation related survey that's ever conducted. So if we do that, we'll find that answer, but that doesn't matter. The only thing that matters is if, for example, the relative of someone who's deceased is very much against this process, then we shouldn't proceed. Like, that's very reasonable and clear. And,
I suppose.
but if they're in favor or they're happy with it, then it's fine.
You see, Jerome, I suppose all parties have some sort of bias to hold this whole thing. The transplant group has bias in terms of, yes, we want increase in donation to happen. If you look at, if you look at the recipient side, yeah, they want good quality organs. If you look at the ICU guys, they want the patient out of the place. If you look at patients, they do not want to look after the sort of moribund vegetable-like state patients, okay, as far as DCD patients goes. So it's an interesting paper what Dale Gardner from the UK, he put up that UK paper a while ago, and where he says in the 2007, the 2007, 2007 to I think 2011, the DBD donor rates went up only by 7%, whereas DCD rates went up by 311%. So I just feel, but somehow they all seem to be happy with the idea of, yes, everybody, let's do DCD donors. And we are still stuck with this thing about, death, the definition of death. I don't think we are, I think, barking up the wrong tree here as far as death and, defining death goes, because we'll never be able to define death. But in the UK, from what I'm seeing from the papers, that they're very clearly defined. Okay, this is what we are going to define. Let's work towards that. Here, I think the surgeon should lead that way. If you look at this group now, what we have on the panel, maybe you should put up a vote and see how many people are happy to give antemortem heparin and how many are not. I'm definitely happy for antemortem heparin to happen.
I mean, what I would say, Santosh, is that, until the patient is deceased, the decisions about their care should be between them and their intensive care colleagues. I mean, I wouldn't object to it, but I wouldn't also insist on it. I think, actually no one's ever asked me. Like, I don't. That's not something that we face in New South Wales, having a discussion about what we feel with respect to antemortem interventions. But anyway, I'd be interested in everyone. Is there a mechanism for voting? How do we?
We could just put up
raise hands or something. Or...
We could just put reactions as
anyone who raises their hand is in favour of permitting antemortem heparin if it's acceptable to the intensive care team and the patient's surrogate decision maker. You
said permitting, not.
Sorry, I tried to put my hand up, but I found I lost.
No worries. We'll put you down as a yes.
So, but basically, I think the standard practice, I think the Victoria giving heparin and the New South Wales, as you said, don't. W, I think is giving as well. I think it's basically state service. I think if your state studied, if you haven't studied, you can argue with your intensive care staff. That's the, as you mentioned, Jeremy, that's the.
In Victoria, it does vary from hospital to hospital. So each hospital has their own policy.
Okay.
And we just accept that whatever they give, they give. And if they haven't given it, we'll give it on the table.
Yeah, interesting. But was to unify, at least in Australia, like a nationwide, I think it's something being patchy for many years.
The concern would be if it has to be national, it had to be no, wouldn't it? Because that would be the only thing that'd be acceptable to everybody, I suppose. So
I think there's just one other point I wanted to make, which is, you know, when you read the literature, particularly the literature which is written by people who want to make primarily ethical points, they actually have a very different perspective from mine, in a surprising way. So, for example, the people who think that you know that there is a constituency for disposing of the dead donor rule. In other words, no longer using the dead donor rule, and this constituency places greater importance on the consent expressed by the donor themselves, either before death through, for example, a advanced care directive, or registration with through license systems. And they would say that if this process made it clear that that a person was in favor of donation, should their situation become such that it's in their interest, according to their intensive care team, that they consent to becoming a donor, even if not deceased by whatever criteria we use, then that's acceptable. In other words, the consent supersedes the dead donor rule. But by the way, the dead donor rule is not legislated, unlike the uniform definition of death. The dead donor rule is a function of common law. In other words, if someone is not dead, then you can't do these things to them. But if they are dead, then you can. So, but for me, I feel very strongly about the dead donor rule. Like the dead donor, because the dead donor rule is just a tautology. It's just like, it means you can't be a dead donor unless you're dead. And then, or you can phrase it any way you like. A deceased donor, a deceased death cannot be caused by donation for a deceased donor. Whatever way you phrase it, it comes back down to a tautology. To be a dead donor, you have to be dead. So then fundamentally, the question is, what's our definition of death? So it all comes back to what's the definition of death. And, for an ethicist or a legal mind, they don't think because they're not involved in the actual process, they don't think about what it means for them personally. So for me personally, as a transplant surgeon, I get a great deal of comfort from the fact that the person has undergone circulatory arrest, and then we waited 5 minutes and they didn't stand up, get off the table and walk out. Or, for example, when I see the neurological declaration of death form indicating that they are apneic, they have no pupillary responses, and I can look at their CT brain and see that they've got a horrific brain injury. When I see that, I feel a great deal of comfort. So if someone were to say to me that that's not important, I would say, well, maybe it's not important to you, sitting in your Macquarie Street office, but it's really important to me. In other words, the dead donor rule is, in that circumstance, not a tautology. It's a way of bringing comfort to the team doing the surgery. Brings comfort to the intensive care team, knowing that even if they do have some mixed motives about their reasons for bringing forward the patient for donation, in other words, they think it's in their best interest, but also they do want to get them out of ICU or whatever, that they're not driving this process, that the fundamental issue is that the person has died by whatever definition. So it's not simply a tautology, but it actually brings comfort and as much certainty as you can to the three parties fundamentally involved, the surrogate decision maker, the intensive care team, and the transplant team.
Bulong, I was just wondering whether through the transplant section, is it possible for people like Jerome to actually sort of, we can make some sort of a document and then get all the transplant surgeon to say yes or no, and, and then develop some discussion with, because right now everything is going through TSNs. So probably it's time to just, where there is a mixture of physicians and surgeons on board. So this being a purely surgical driven thought and process that's involved, I think the transplant section of the college should take the lead. What do you think, Bulong?
I think it's a very good topic today, and Jerome, I think Jerome probably also knows this, like basically Australia Organ Authority also been working on these projects for normothermic regional perfusion. As I mentioned, like Helen is the director of this service, and also the co-author for the paper just published on the transplantation, talking about the brain death definition in terms of regional normothermic machine perfusion as well. So I will forward this paper to everyone here today. And also we will get this video to cross to Helen to have a look, and we can continue work on this project along with the TSNZ, society as well. I think, everyone will play the role to continue improve the organ quality in this regards.
I think that's really important, Belen, because I think none of us are really interested in being public intellectuals. Like, I don't want to be, I don't want to be out there writing papers, promulgating my opinions about this problem, but we do need to solve it, because otherwise what's going to happen is, we in 20 years time, we'll still be going to international meetings, hearing about their outcomes of
Totally agree.
of
We need to
NRP.
work as a group to continue push towards basically, organ authority will work on this as on the organ donation behalf overall.
Yeah, I think that's right.
We play our roles in this, area. I think we should put efforts, particularly your topic tonight is really interesting and very valuable.
Yeah, I think the one contribution we want to make to their process is that, if they can find a definition of death that's satisfactory, great. But we can't rely on some third party to come up with some definition. And I think if we can just move the discussion past that point, then we'll, as a group, be able to make great progress.
Absolutely. We also got Amanda here, and Emma just disappeared. Amanda, do you have any comment on this? Tony? Okay, I probably leave to you to conclude the meeting tonight, Jeremy.
Thanks, Santosh. I'd really like to thank Andy for all the time he spent putting the presentation together. That was really a fantastic summary of the issues, and I think I'd like to thank everyone who was listening and who contributed, and I really hope we can bring this discussion forward over the next few months. Thanks so much.
Great. Thank you, Jeremy. Thank you, Andrew. Thank you, everyone. See you next time.
Thank you.
Bye.
Thank you.
Thank you, Kathleen.
Thanks, Kathleen. Bye.
Everyone.